Next. Okay,
Yes.
so these are the areas, I think we're there. Thanks for that, Martin. So these are the areas I'm going to be looking at, drawing on statistics as I go. Everybody knows that well, a lot of people know I'm not a statistician, but anyway, for me, the starting point is always the funding situation for the NHS. I think this creates the possibilities within the NHS, what it's actually sets some parameters as to what it could actually achieve. And there are some killer figures for me here. I've come back to them time and time again over the last few years, that between the creation of the NHS in 1948 and 2010, you've got annual real terms increases in NHS funding of around 4%, just a shade under 4%. So Labour governments are funding more generously, the Conservative governments, it's not the same funding increase every year, but that's the average. And then suddenly we're plunged into a decade where we have annual average increases of just 1.4%. But actually the cost pressures on the NHS, so when you think about the ageing population, the technological advances which require more money, changing profile of morbidity, more chronic conditions and so on, the cost pressures on the NHS are actually 4% a year. So as that decade has gone on, you've had costs going up by around 4%. Actually, they're trying to hold those down, but you've got funding going up by, on average, 1.4%. So you get this gap opening up. And what that does is it creates this tremendous pressure on the system to change the way it's doing things and to change the way it delivers healthcare. A lot of the brunt is borne by NHS provider organisations, especially acute hospitals, where the price that they're paid per procedure is slashed in the early years. And sure enough, by the time we get to the start of the pandemic, we've got £14 billion worth of debts across the system. We do get more generous funding from 2019 onwards, but it's not enough. So essentially, we were getting before the pandemic about 3.5% increases. But NHS providers, which represents hospitals and other trusts, says that at least 5% is needed to recover performance and to transform, change the service. So we've got very, very low levels of funding in historic terms. I think this reflects an ideological commitment on the part of the Conservative and Conservative-led governments to reduce the public expenditure as a proportion of GDP. At the same time, they're pushing through the 2012 Health and Social Care Act in the early years, which is a very expensive way of running your health system, but which signals an intention to expand the role of the private sector. And I think this is allowing more private sector involvement is something which I think is consistent with this level of funding. Now, I now want to turn to the workforce. You don't need to look at all of the figures here, but the top part of the table, this is comparing 2010 and 2020. So where were we just before we went into the pandemic? And the top half is just the main staffing groups. And you can see that staffing as a whole increased by just under 12% during that decade. You notice that support to clinical staff, so these are clinical workers, but they are not, the fully professionally trained clinical workers. Healthcare assistants, nurse support workers, that proportion of the workforce increases much more significantly. But I want to draw your attention to this figure here for nurses and health visitors. The vast majority of these 300,000 staff are nurses. We've only got a few thousand health visitors. And just look at how that is lagging behind. We have a real problem. We have a real problem with all our professional groups, but particularly with nurses. And by 2018, we have a full-time equivalent workforce shortage of 100,000, just over, and the largest single group of those are nurses. We've got turnover rates that by 2019, and incidentally, the turnover rates before 2019 were a bit higher, but turnover rates of nearly 12% amongst nurses, 13.5% amongst mental health care clinical workers. And yet, despite the fact that the NHS is its workforce, that you cannot have your health service if you don't have a workforce, in fact, the workforce is not prioritised at all in the array of policies that we see over the last decade. Successive governments have refused to get to grips and produce a proper workforce strategy. And in fact, what we see is that the education and training budget is cut. Over the years, there's a reduction of about 5% over several years during this decade. And from 2017 onwards, we see that the nursing, midwifery and allied health professions bursary is cut, is abolished, which doesn't help either. So you begin to wonder, why are the workforce not being cared for? Now, when you look at the reasons why people are leaving, it is consistent with the experience of working in a service which is underfunded, where there's constant pressure within organisations to try and cut costs in the way in which things are done, where staff are redeployed in order to make more efficient use of the workforce and so on. So you get these comments about the work-life balance, essentially the difficulty of leaving work when your shift comes to an end, working conditions which are very onerous and which are stressful. And I think we should remember as well, and certainly 2/3 of trusts think that the pay restraint policy of the last decade, where pay has been either capped at about 1% or it has been frozen for most of the decade, has actually contributed to difficulty in recruiting and retaining staff. Now I want to have a look at our capacity in terms of beds as we went into the pandemic. And we've got figures here for 30 years ago, the late 1980s, then 10 years ago, and then the period just before we go into the pandemic or right at the start of the pandemic. What you can see here is that this is the number of beds that we have as we go into the pandemic, about 141,000. You'll notice a significant decline over the previous 30 years. And I think a lot of that is for reasons of trying to care for more patients, including mentally ill patients in community settings rather than hospital settings. But changes in cultural practices around maternity. Women don't expect to spend a week in bed when they have a baby anymore, as they were back in the 60s and the 70s. You can see an increase in day beds. So that reflects technological changes which have made it, advances in medicine, which have made it possible to do overnight, to do daycare and to treat people with less invasive measures. So and I think it's quite interesting that despite the fact that there is increasingly demonstrable pressure on our beds over the last 10 years, and despite the fact that even Simon Stevens, Chief Executive of the NHS, is expressing concern about the pressure on beds from at least 2019, actually the beds have continued, bed numbers have continued to decline year on year. And I'm very aware of the pressure on our beds locally. You hear about operations being cancelled, and you wonder whether sometimes people, may be being discharged too soon. And then when you look at our bed numbers in comparison with the OECD average, you begin to think, well, maybe there is a problem here. Maybe we do have a problem. I mean, I have even heard over the last few years when they've been trying to reconfigure services, arguments being made by local NHS leaders, that we have too many beds in the NHS. But I just don't think that argument stacks up at all. There's a tremendous pressure, anybody in an acute hospital will tell you, there's a constant focus on trying to find beds, trying to discharge people as speedily as possible. And our bed numbers are not promising. And I include the Germany figure there because Germany has managed the pandemic much better than we have. And if I were hypothesizing about that, I would say that one of the reasons for that is probably that they have better capacity. They have more capacity in their health system than we do. And this is true also of intensive care beds. So these are the numbers of beds we have across the UK for adults. And Germany, again, is much better provided for than we are. So I think in terms of capacity, we had a real problem when we went into the pandemic. We don't have enough capacity. And I think, you know, you can look at these kinds of indicators of that you've got almost a sixth of patients waiting, you know, on the eve of the pandemic, waiting more than 2 weeks to get for a GP appointment. Most of those don't want to wait that long for a GP appointment. In February 2010, you have 90% of patients being treated within 18 weeks of being referred. But by February 2020, only 83% of patients are being treated within 18 weeks of referral. In February 2010, we've got a waiting list of 2.3 million. By February 2020, we've got a waiting list of 4.4 million. And at the same time, the NHS is taking numerous measures to try and reduce demand, such as scrutinising very carefully the referrals that GPs make to see if they're really necessary referrals, removing items from the free NHS prescription list, and even removing some procedures from routine availability. Another consequence of this constraining of capacity, bearing down on the capacity, almost trying to contain the service, is that we see more outsourcing to the private sector. Now, the NHS, the Health and Social Care Act of 2012, actually made it unlawful for commissioners, who are now called CCGs, clinical commission groups, to prefer NHS providers. You had to treat any provider, you know, who might be offering services, you had to treat those equally within a competitive regime. And the any qualified provider, which means if a company or an organisation is licensed to provide NHS care for a particular procedure, then if a patient chooses that procedure, the NHS will pay. So, for example, when my mum had her hip operation done last year, she chose to go to a local private healthcare provider rather than waiting many months or even over a year for the local NHS hospital, despite the fact the local NHS hospital had given her excellent care for previous knee operations. So these very lengthy waiting lists that we have in NHS organisations actually incentivises patients to choose non-NHS providers, who invariably have much shorter waiting times. But also the shortage of our bed capacity in hospitals has an impact, particularly in the winter, when we know that we are going to have an increase in emergency admissions. And what you find is that, you know, fewer elective procedures will be scheduled during those months, but also because you need theatres, you need availability of intensive care beds when you're conducting operations. And what happens is we're told the NHS hospital must prioritise the emergency admissions, and it encourages CCGs to contract out some of the elective care to private providers to keep the elective care ticking over when the NHS only has capacity for its emergency admissions, or primarily for its emergency admissions. But also what we are seeing is that NHS providers themselves are increasingly contracting some of their own work out to private providers in order to meet their waiting time targets. Now, what this has led to over the period is a greater interdependence between the private and the public sector. So, and this includes the private acute sector becoming much more reliant on NHS revenues for its own income. So look at that tremendous increase in the space of a decade or so. But it's also entrenching the NHS's dependence upon the private sector. And this is work done by David Rowland of the Centre for Health and the Public Interest. And what he's looked at, he's gone back to the accounts and the annual reports of the department, and he's looked at the total expenditure that is made by within the NHS from private sector providers of services. So this is providers of health services. And what you see down here is you see that there's been an increase between 2013-14 and 18-19. So we're now at about £30 billion of expenditure on the independent sector. And a big chunk of that is made up of hospital and community health services. So these are services outside you know, GPs and outside dentists who have traditionally been independent contractors. And that share of total expenditure on the independent sector is increasing. So, you know, 40-something% of what the NHS is spending on privately provided health services is actually accounted for by the hospital sector and the community sector. And notice that from a very low base, but nonetheless a rapid rate of increase, hospitals and other providers, mental health trust providers, commissioning private providers to provide some services for them as well. Now, I want to say a little bit about the NHS estate here. This is because, you know, the experience of COVID has made us think about how we need to use NHS estate, the need to have space for surge capacity, the need to be able to separate our COVID patients from our non-COVID patients. But do we have that estate? And I'm very aware that there's this tremendous pressure at the moment to rationalise the NHS estate, to sell off NHS estate where possible, to really sweat the assets. And I'm kind of wondering whether that is a sensible thing to do, to the extent that we're doing it from a pandemic readiness point of view. So you can see we've already had a significant reduction in the number of hospitals within the NHS since the creation of the NHS. I don't think that's particularly surprising, and I don't think it's a particularly bad thing in itself. But we do have this very strong emphasis in policy at the moment on trying to reduce the amount of care that's being given in hospital settings. I would even go so far as to say we have a very anti-hospital care narrative at the moment. In a lot of the NHS discourse. Now, these process reconfiguration means physically reorganising your services, and these predate the last decade. You know, that we've been trying to get as much care as possible out of hospital into community settings, that where care has to be provided in hospitals, then try and concentrate it into as few hospitals as you possibly can, centralise your services. But it's been reinforced by the restricted funding, which is forcing the NHS to find different ways of providing healthcare, and this new models of care policy moving towards integrated care, which is trying very hard to reduce the amount of care which is being given in high cost settings. And your high cost settings are your acute and specialist hospitals. So they're trying to reduce that care and get care into much cheaper settings like patients' own homes. Now, you get Lord Naylor, who comes in 2017, and he reinforces this process by saying, you know, look, you've got NHS organisations, you know, our local hospitals, our mental health trusts, etc., sitting on assets which are worth, very rough estimate, 9 to 11 billion pounds. He says he thinks the NHS needs about 10 billion pounds of capital expenditure. We've seen cuts to the capital budget during the course of the decade. And he said, well, you know, those organisations could be incentivised to sell off some of their assets. He thinks that maybe going on for £3 billion could be raised that way. And then those organisations could use that revenue in order to improve the quality of their remaining assets. So all of this is kind of reinforcing this think lean, think mean kind of approach to a state. And yet the experience of the pandemic is that actually we needed flexibility in the use of our state. We needed alternatives. We needed to be able to space people out. And I lifted this shamelessly from Wikipedia. Thank you, Wikipedia. But just because it shows, you know, that we used to have Fever Hospital. These are actually figures for the just before the First World War. But actually, you still have loads of Fever hospitals that are incorporated into the NHS when the NHS is created. But most of those have closed down by the 1960s. But I think the question is, do we need to rethink our estate policy with a view to having more redundant capacity, more flexibility in the service? Now, and again, this is just very, very briefly, and this is just, I'm just illustrating here the fact that the NHS has been focused on pretty much anything other than pandemic preparedness, over the last decade. Not only did we have the 2012 Health and Social Care Act, restructuring the health service so that it became a different kind of turbocharged competitive market system. But since Simon Stevens came in 2014, we've had a different process of top-down reorganisation going on. And this is about trying to turn the health system into what is described as an integrated care system. And this is a system of population health management. And I just wanted to kind of flag up that, you've got, the NHS doesn't know how to do this itself, so you have to bring in this quote unquote assistance from different organisations. The vast majority of these organisations that are involved in this are commercial organisations. A good chunk of them are from the United States of America, and they are assisting NHS organisations in reshaping themselves to become organised around the principle of population health management. So if you like, you've got that link takes you through to you can see all of the lots, all of the different categories of assistance. You've got stuff around records and around patient activation and patient empowerment and helping with IT systems and so on. But my point is that the NHS has been very focused on reorganising and completely reconfiguring the way it works. And it kind of goes into a pandemic, in that place rather than in a pandemic in a position of pandemic readiness. Now, I just want to say a little bit about NHS 111 and primary care, because obviously these were kind of the gateways to some extent for healthcare, and certainly we see in early 2020 that the primary care system is under intense pressure. The number of appointments each year seems to be going up, but our GP numbers have actually been declining since 2015, despite an increase in the number of training places. And a lot of this is to do with the fact that a lot of GPs don't want to work full time. Indeed, some of them are arguing that they cannot work safely full time because their days are so long that just working 3 10-hour days or 3 12-hour days is exhausting enough, and that they couldn't practice safely if they were working. So you've got now 45% of GPs who are working less than full time. Increasingly, GP appointments are actually being taken by people who aren't GPs, are being fielded by other healthcare workers. So that's interesting. We've moved to a multidisciplinary team model, which has been quite a deliberate policy. So certainly by the time we get to January 2020, the government is not in a position to instruct people just to ring up their GP if they think they've got a problem with COVID. And patients are advised instead to use NHS 111. But in fact, although NHS 111 sets up a special COVID-19 clinical assessment service, actually it doesn't have the professional staff that it needs to fund that. But I think there's something else that's kind of a bit of maybe this should have been ringing alarm bells at the time, that when you look at the number of calls that NHS 111 was taking prior to the pandemic, you discover that even then they weren't able to answer all of the calls that were made. Now, maybe they would never have answered 100% of calls anyway, because, maybe some people ring up, change their minds and put the phone down again. But notice how, in these months, and I've been looking at the earlier months as well, so back into 2019, it's fewer than 90% of calls that are being picked up. But look what happens here in March 2020. You get this massive spike in the number of calls made to NHS 111 around COVID-related concerns. Fewer than half of those calls are actually picked up. And you can see it maybe a little bit better with this graph. This is from the Health Foundation. And you can see on the left-hand side here, you've got a figure that shows this tremendous spike. The red shows the spike in the number of calls to NHS 111 right at the start when the pandemic has gripped us, really. Of course, the pandemic was starting in January, but when it has gripped us. But when you look here at the second little graph on the right-hand side, you see that there's no spike. So essentially, it seems to me that NHS 111 had not been able, NHS 111 is NHS funded, but it's actually provided by a diversity of organisations, including private sector organisations. But it seems to me that NHS 111 had not been in a state of readiness. And of course, as we know, public health was not ready either. And I think it's one of the tragedies of the 2012 Health and Social Care Act that the public health was split three ways. You've got some of public health in the NHS, you've got some of public health in local authorities, and then you've got Public Health England, which isn't in the NHS and isn't in local authorities either. It's an executive agency within the Department of Health. So you've had this three-way split, which complicates the process of communications, disrupts effective communicating, and has reduced the coherence of the public health response, despite the greatest efforts made by those actually working in the service and those leading the service to do their best. And I'd love to have more information about lab numbers, but the numbers I'm presenting here are to do with the budget, and you just can't believe it, but they were actually taking money deliberately out of the public health budget and giving it to NHS services. So I think what we see here is a real, despite the fact that population health management is actually supposed to be playing up public health and preventative work, what we see here is the really, really low priority that is given to public health. You're talking here 3 billion out of maybe 130 billion budget, you know. So now, of course, a lot of public health has been moved into local authorities. Lots of us supported that move at the time as a good move in principle. But of course, everybody was aware that that transfer was made just at the point that the coalition government had decided to slash the central government grant to local authorities. So public health transfers over to local authorities. That pink splash of colour there shows you the value of the central grant, and you can see it declining over time. And although initially the public health budget is ring-fenced in local authorities, that comes to an end, and then there is no further ring fencing. And what I want to finish it on is just a few words about social care, because the NHS is very reliant on social care. And as I've just mentioned, local authority funding has been slashed over the last decade, and you know, this has had a tremendous impact on social care. In fact, by the time you get to January 2020 and the eve of the pandemic, the spending on social care is still below the level that it was at in 2010 in real terms, despite the fact that you've got more people who are over the age of 65 and more people who are in need of social care assistance. And in fact, Age UK at the bottom of that screen, Age UK calculates that about 1.5 million people have unmet care needs, because what has happened is that eligibility criteria have been tightened up so that you can only get publicly funded social care if you have, you know, the most severe forms of social care needs. And we have a tremendous gap. You know, it's also true to say that while the NHS is largely publicly provided and publicly funded, that wasn't the case with social care. The social care has always been in mixed ownership, and you know, it's always been means tested. And this, again, this is a Centre for Health and the Public Interest analysis. This just shows, you know, how reduced the local authority contribution to the provision of social care is. So in terms of residential care, only 6% by 2012, and domiciliary care, which is home-based care, just 11%. And I think that those numbers will almost certainly have declined over the last few years. And what we have in social care is we have an incredibly fragmented sector. So you've got over 18,500 organisations providing social care, 1.5 million people working in it, overwhelmingly a female workforce. You've got 45% of your employees working for very large organisations. In social care, you've got transnational corporations, you've got large national companies, you've got small businesses, you've got large national charities, you've got small local charities. It's a very fragmented and differentiated service, as well as 145,000 people working for direct payment recipients. And you can see here how the workforce is spread across the different sectors and what a strong contribution the private sector is making. Now, the story from a workforce point of view is a sorry story. You've got very high proportion of people working on 0 hours contracts. Actually, if you go to domiciliary care and you look at domiciliary care workers, the direct care workers, something like 58% of them are on 0 hours contracts. The wage is a little more than the minimum wage. You've got a largely unregulated workforce. Most workers do not need to be on a professional register, and most of them don't need to have any qualifications in order to provide care. So indeed you have, this is from Skills for Care, the annual report, and you've got a very, very high level of turnover amongst these staff. So there's tremendous dissatisfaction. I'm in touch a lot with domiciliary care workers at the moment because my friend receives domiciliary care, and there is a tremendous a tremendous turnover and a tremendous dissatisfaction with just the sheer imposition, constantly being called in on their days off, constantly having to work very long days. And just look at that. If you've got a turnover of 31%, that means you lose 440,000 of your staff in the course of the year across that sector. So you've got a tremendous churn here and a very high vacancy rate. So there are genuine concerns about this. And of course, what that means is that providers rely on agency staff. You don't get the skill mix that you want. You get a bit of a production line approach. I couldn't find out what proportion of care workers are or how many care workers are in trade unions, but those figures probably don't exist. And I'll just finish with this. What we're dealing with social care is a fragmented sector, which I think has made it more challenging to kind of roll through policies. Providers have done their level best. They have done the best that they can for their residents. But, or in most instances, there have been some scandalous stories. But we have a shortage of provision. And you might remember that quite early on in the spring pandemic, we had a mass discharge of frail elderly patients to residential homes without testing, and to residential homes, many of which were unable to space out their patients. They didn't know anyway which patients had COVID. They weren't able to separate COVID from non-COVID very often when they did find out. And we know that the reliance on agency staff actually helped spread the transmission of infection. And up until quite recently, something like a third of deaths actually occurred in residential settings. I mean, a complete tragedy. But I think particularly what struck me was the unorganized character of that workforce meant that where we were seeing nurses and doctors on our screens early on in the pandemic, screaming out for more PPE, constantly driving up the pressure on the politicians to get more PPE, we didn't hear that voice from care workers, because those care workers weren't so organised. Yes, eventually, from maybe late April onwards, we get much more attention on the residential sector. But I can't help feeling that if that workforce had been better organised, and if the cultural and political salience of the care sector had been greater, lives might have been saved by having a stronger political profile. So overall, with the NHS, I think we have a service which wasn't big enough to cope with the pandemic. It had no flex. It had no redundant capacity. There was no slack in the system. It was preoccupied with reorganisations away from a market system towards a care system. It was in the midst of a very anti-hospital care narrative, whereas of course to save your life we need hospital care in the pandemic, and it overall weakened the pandemic readiness of the service and its ability to respond adequately to the pandemic. I'll finish there. Thank you.